Now, clearly some important, thank you, Dr. Peter McCullough, for your time and for joining us early this morning. Now, we've got our medical panel now, who I'm sure may or not have differing views. And if you wish to rebut or comment on what we've just heard, please feel free. Now, to move into our next section from what we've just heard, we're going to talk about how do we learn to live with the virus. We've heard throughout today the damaging effects of lockdowns and other interventions. So the question becomes, what is the alternative? What is the solution as we move forward? Can we learn to live with the virus? So to help us address that, Professor Karol Sikora returns to the panel. Great to have you here, where we're going to address this question. Of course, as we say, if you want to comment on anything that's gone before throughout the program today, please feel free. But firstly, early last year, we heard about the risk profile of the virus. And we understood that the elderly and other sick individuals were primarily at most risk from COVID-19. Prior to the rollout of the vaccines, why didn't we take a focused approach? And is there such thing as a focused approach that could be applied to tackle COVID-19?
Infection. Basically, there were three groups of people. So we have a room here, maybe 50 people. We all, some of you are infected now, hopefully not. Hopefully you're PCR negative, but there's maybe a possibility. Some of you may well be immune, either through the disease itself or through vaccination, and some of you may be susceptible. Now, within that susceptibility group, there are some that are more susceptible to illness than others. And we know what the criteria are. Mainly age, so older people, fatter people, certain ethnic minorities, and then on top of that, people with comorbidities, liver failure, heart disease, diabetes, all the other things that we accumulate. And if you look at the patterns of mortality from COVID anywhere in the UK, anywhere in the world, you see the same patterns. And as I said earlier, the average age is 82.5. Nearly all of us in this room are half that age except me, so you're doing well. I think as we move forward, can we get the other thing we learned about as students was herd immunity. That was a concept that was drilled into us. And that's what the Great Barrington Declaration was about, and what the whole row right at the beginning is, can we get herd immunity by letting the virus out there? And the argument, would it have saved more lives or not? So the current thinking is more about stratified vulnerability. We all have risks. We all are willing to accept certain risks. So I'm going to go on a train after this, and to get hit on the head with a rolling pin by my wife. I think the rolling pin is going to be harder than the train in terms of risk to my body. But there's no doubt that stratified vulnerability means you can try and predict who is most vulnerable. The government did a good job with vaccination as a logistic exercise, despite what we've heard. As a logistic exercise, it can't be faulted. And, it began with older people, and it went down the list. And that was the crude way of doing stratification. I mean, you could have added ethnicity, you could have added obesity in there, but simply doing it by age was a simpler way of doing it. And I think the question, and everyone, how much voluntary risk do you give to people? That's a fascinating question. In other words, how risky do you feel about life, and how risky do I feel? And is it different, and why is it different? And do you actually take that into account? And, in treating cancer now, patient options are given much more vocality. We explain what the options are. This is the deal. You choose what you want. And it causes a lot of stress sometimes for the oncologist as well, because patients often choose what you wouldn't expect them to choose. And the same with this, I guess. I think as we move forward, immunized population, disease population, more and more people have had the disease, so we'll get there. But I think that the difficulty is the enforcement of it. Now, when I get on the train on Monday, am I going to wear a mask? No. Do I care that someone sitting next to me wears a mask? No, I don't mind. You can wear a mask if you like. But that is me not allowing for the person next to me. And that's the whole business, whole of society going forward. But I think we are in a relatively good place at the moment. I have to be positive at this thing. And I think that was a great talk, by the way, Peter McCulloch. I thought that was just spot on. He's obviously an oddball in the American establishment. I think you could get that definite feel that he's not going to be invited to Capitol Hill anytime soon. But he's got a point. And if you look at the recovery trial over here, it was a point. Every doctor knows steroids. If you don't know what to do, shoot people up with steroids. Massive doses. A gram of solumedrine was the old trick to wake someone up. If they didn't wake up, you called the undertaker. And so this was, there was no doubt that was a logical thing to do. And what he did very well was put a protocol together involving a whole range of things at relatively low doses. So it was relatively safe medication, safe for people to be at home, which is quite remarkable in a hospital, because he's a hospital physician. He's not used to working outside the hospital in the pre-hospital environment. So I think it was a fantastic presentation.
Okay, now, you mentioned the kind of vulnerable in some of the categories. Now, one of the most vulnerable we've seen is care homes, and it's been quite a controversial subject in the United Kingdom and other countries as well, in terms of what could we have done better. I think one of the objections to a more focused strategy is how do we truly protect the most vulnerable, albeit care homes or otherwise. So in order to avoid blanket restrictions and mandates, I appreciate lots of the things we've talked about today is around the ideology of it, but actually in a practical standpoint, how do we truly protect the care homes, and did we get things wrong, and how should we readdress the balance?
Yeah, let me talk about something else first, then I'll come to cancer patients. I know about how we do it for cancer patients. Cancer patients often say, am I more vulnerable? And, depending on the various circumstances, if they're on chemotherapy, if they're on radiotherapy, certain parts of the body, if they've got impaired liver or kidney function, they are more vulnerable, almost certainly, to any illness that comes to them. So for them, we can do a sort of assessment of them, a medical assessment. The care homes are different because they're not in a medical facility, they're in a care home. They get nursing, often by non-nurse professionals, by healthcare assistants, and they don't have blood work regularly, you don't have x-rays regularly, there's no medical notes as such for the patients. You see, I used the wrong word, it's not the patients, the clients, or whatever we call them, in the care home. And I think that's the problem. Who's going to make any assessment of them individually? So all one can do is blanket rules. And I think we got it wrong, well, someone got it wrong a year ago and let people out of hospital that were positive for COVID into care homes. And that was clearly an error. And no one's really got told off for it, as far as no one got fired because of that. They get fired for screwing an assistant, but not for nice way to do it, So I think as we move forward, some sort of policy for care homes, because clearly care homes have a series of vulnerable people in them because of age. What's interesting, if you go into a care home, and I've been into several, there's not that many obese people. So that's one risk that's gone, because it's thin ladies in a care home, mainly. I mean, there are some gentlemen as well. There's a gentleman's table usually. And, but it's interesting because longevity goes with physical fitness and therefore thinness. So it's an interesting concept. The other problem is dementia and the associated dementia with COVID, which is not really proven. And it is difficult for society. And the last point I'd make on this is what's the value of a life? And that's something you face quite a lot in cancer, especially if there's expensive therapies that the state won't provide here or the private insurer won't provide in insurance-based systems. Is it worth spending $100,000 to get 6 weeks extra of life with an expensive drug, for example? What's it like for a care home? Should you be making people vulnerable and excluding them and protecting them from COVID? So you isolate them, and the last year or so is severely affected socially by the theoretical imposition of the virus. And people in care homes want to have a life too, and I'm not quite in that generation yet, but I can see that coming. especially when the rolling pin dents me and when I get home. But seriously, I think care homes are going to be an issue as we move forward.
Now, we've seen, obviously, unprecedented levels of lockdowns. We've seen interventions that we've never seen before, or at least not at scale. We've talked about how the pandemic rulebook was thrown out to tackle COVID-19. But in the process of doing this, we've also seen those policies normalized and even moralized, as we've, again, discussed today. So what do you think is going to need to happen to shift from that mindset now, whereby a large majority of the population, I would suggest, have become accustomed to this type of policy as a way of dealing with COVID-19, to actually shift with the idea that we can live with the virus without losing copious life?
It's going to be a huge challenge, especially as everyone's been so scared. When I look at my kids that are in their 30s, and they have families, young families, and they obey the rules. I mean, it's ridiculous. I say, come on, kids, be a bit naughty, take the mask off in the swimming pool, for God's sake. It is, and I can see a whole generation have been scared, and they're doing it for the sake of, in turn, for their children. They think somehow, who are not going to be affected. And the arguments about schools are clearly very potent, that we've got it wrong with schools, and it's still not right. And even though we're entering the proper recovery phase next Monday, it's only 2 days, 48 hours time, and yet we're sort of dithering as we go forward. Part of the problems are the mutants, because they change all this susceptibility, immunity, and infected. You may be dealing with essentially a new infective agent, but we've got to get out of this, and there are going to be lots more viruses, and we can't PCR everybody that goes through Heathrow just because there's another virus floating around. We've got to get away from it somehow.
Thank you. And our last question is really around you mentioned the Great Barrington Declaration, focus protection, herd immunity. These concepts were, again, politicized in 2020. The idea that we would just let the virus rip was a phrase that was used over and over again. So again, it's really difficult for people to get to understand the practicalities of living the right. What are some of the practical things that can be done? Because again, to go from 100% lockdown to 0%, people's perception is that that's a dangerous move. So what comfort could people take? If we were advising the government now in terms of how it's going to be okay to move forward in this way, right, what are some of the practicalities that need to be considered in order to adopt a focused protection strategy?
I think there are lots of metrics you can use. I mean, you can use surveys of the virus, which are done as a survey, not as for the whole population, just for a selective survey. And you can use metrics of hospitalization and illness, nothing to do with COVID, and then to do with COVID. But we heard about the dangers. A lot of the people that are called COVID admissions are not really, they've had heart attacks and they're positive for COVID, and the reason for them being in hospital is not the COVID. So I think we can use the metrics, but the main thing is to carry the population with you and getting away from the doom mongers and the sort of Jobsworth that are policing the system. Someone for Christmas, my nephew, gave me a COVID police luminescent jacket. It's fantastic. It breaks up parties, but you get a stick and you walk, oh, hello, hello, hello. This is an illegal gathering, and people jump to attention. I should have brought it here today. But there's no doubt that going forward, we've just got to go and get us out of here. And that's why I think this sort of grouping, this sort of meeting is fantastic, because it's not going to be reported, just like the demos. It's not going to be talked about much outside the group, but people know it's happening. So I think it's a powerful voice.
Thank you. And we've heard that the greatest risk to your safety is the threat of your wife. He's kindly stayed here because he was due to leave earlier on today, but he stayed with us to give this session. So before he goes, I just want to give the audience an opportunity to ask a couple of questions. But before we do that, we're going to introduce our next speakers shortly, Professor David Livermore and Dr. Anthony Hinton. Do you have any comments to what Karol has shared?
I think that's an excellent summary of the situation and the challenges we face going forwards. I would agree with you, and I'll talk shortly. I think vaccination has been a boon. It has altered the situation and changes the whole nexus with regard to the Great Barrington Declaration. It is protecting the most vulnerable, and that does give us the opportunity to go forwards. But people psychologically have to be got out of the state the government has talked them into. And it's time for the government to say how it is going to do that.
Thank you. Dr. Anthony Hinton, any comments from yourself?
No, I think I would totally agree, but I think it's very important you get home to your wife.
Indeed.
Well, on that basis, we'll take 1 or 2 questions from the audience, please. Gentleman in the back.
You weren't quick enough.
Gentlemen, thank you very much for your wise words. I'm just wondering if you could explain what you think the reason is for the co-opting, it would seem, of the majority of the medical profession to go unquestioningly down the vaccine route and participate in the suppression of information that's being shared here today, please.
Sorry, just say that again.
The whole medical, most of the medical fraternity seems to be co-opted into unquestioning vaccine narrative. Why is that, please?
It's a very strange, and it's difficult to get them out of it. The population won't come out of it. So it was easy to get in, presumably because psychological tricks were used. I mean, such are the adverts we saw this morning, and the slogans. And then it's very difficult to get a population that are frightened back out. I have no real explanation, not being a psychologist. Our psychologist is in the room, but I think it's fascinating to see the use of sort of coordinated onslaught on people's values and the societal requirement to obey, because you want to obey. And the organization that frightened me most was how submissive it was the church. You know, the church, especially the Church of England, shut up shop. And when you said, you know, people died for you to be able to have free religion, you know, people were burnt at the cross for this, they were burnt at the stake for you to be alive. What do you say? And they say, oh, it's the government rules, you know, rule of 6, we can't come to the church. So what about the car park? I mean, do something different. But I think all organizations were struggling to cope with what was going on. And then this obsession, but to show that there were COVID secure and all that, which you still see everywhere. You know, even here, you can see it, the trappings of it. Hopefully on Monday, rip out the things. I doubt it, actually. But, yeah.
Thank you to Professor Karol Sikora. You better get home to your wife now. Thank you so much. Please give your round of applause to Karol Sikora. Thank you.